Good evening, everyone, and Happy New Year. We're just going to give it a few seconds to transfer all the participants in from the waiting room, and then we'll get started. Okay, so again, good evening to everyone and Happy New Year. Welcome to the General Surgical Review Part 2. This is in preparation for the upcoming General Surgery Residency in-service exam. My name is Ivy Haskins, and I will be co-chairing this webinar tonight along with Dr. Michael Awad. I think the webinar is in its 11th, 12th year. Thanks to Dr. Awad who started this. And this is a great tradition. So we appreciate all of your efforts, Dr. Awad, in keeping this webinar series going. So tonight, the topics that we will be discussing include surgical critical care and trauma, breast and endocrine, vascular, as well as some additional and miscellaneous topics that are frequently tested on the ABSITE exam. Before we begin, we would like to highlight that this webinar is possible because of SAGES, which is the Society for American Gastrointestinal and Endoscopic Surgeons. For those of you on this webinar who are not yet members of SAGES, the vision of SAGES is to reimagine surgical care for a healthier world. The mission of SAGES is to innovate, educate, and collaborate to improve patient care. And while SAGES has many values that are listed here, I would like to highlight the unofficial value of fun. In addition to the camaraderie afforded by SAGES, being a member also provides a significant discount for registration to the annual meeting, education and professional development courses such as the one tonight, a network of now more than 8,000 colleagues, an online subscription to surgical endoscopy, members only access to additional professional development resources, and numerous opportunities for involvement. If you are not yet a member of SAGES, there are different membership categories, and I would encourage you to go to the SAGES website to learn more about SAGES and the membership categories available, as we would love for you all to be our next members. So before diving into the topics tonight, I would like to remind everyone to save the date for the 2026 SAGES annual meeting, which will be held in Tampa, Florida this year from March 25th through the 28th. We would also like to take a moment to acknowledge and thank Gore Medical for sponsoring this webinar. The support of partners such as Gore Medical allows us to continue to create and provide quality education, including this webinar tonight. So here is an ABSITE content outline. For those of you who were able to join us on Tuesday, December 9th, we covered the abdomen, alimentary tract, and endoscopy topics. And tonight we will be covering the remaining topics. So buckle up. I hope you guys ate some food, some dinner for tonight. So the way that this webinar will work is that each of our panelists will read multiple choice questions and we will poll the audience to answer each question. And then the panelists will provide an explanation for the answer. We would encourage you to use the Q&A element of this Zoom if an answer choice still does not make sense to you after the answers are explained. All of our panelists, as well as myself and Dr. Awad, will try our best to answer those questions as we move along. And we will also try to provide some additional test-taking tips and strategies throughout this webinar. We would also like to thank TrueLearn, which is the question bank that we will be using this evening. TrueLearn combines high-quality exam-style questions, comparative analytics, learning science principles, and individualized testing behaviors to guide learning and increase performance on high-stakes exams. So, without further ado, I would like to introduce our first panelist, and that is Dr. Maggie Bosley, who will be taking us through the trauma and critical care questions. She is currently an assistant professor of surgery and the program director of the Abdominal Core Health Fellowship at the University of Oregon Health Sciences in Portland, Oregon. She is a phenomenal teacher, and we are so excited to have you back again this year, Maggie. Let me pull up the questions.
Our application for fellowship is currently open. Small plug. You can go to our website. Man, this is small font. I'm getting old. Okay, first question, everybody. An 18-year-old is brought into the trauma bay after a head-on MVC. Thank you. Um, oh, even better. He is cool, pale, and lethargic. After intubation and initiation of MTP, XLAP reveals a large splenic lac and multiple blunt hollow viscous injuries. After damage control laparotomy, he is transferred to the ICU for resuscitation, where his temperature is 35 degrees Celsius, 95 degrees Fahrenheit. Which of the following is the best indicator of adequate resuscitation in this patient? A heart rate less than 100. Sorry, the poll keeps popping up in front of me. B, pH below 7.2. C, base deficit less than -6. D, lactate 1.2 or a temp of 36. All right. I think we can move along. Most of you answered D, which is correct, which is a lactate of 1.2. I think you have to read this question, understanding some of what they're asking, some test taking tricks and tips, reading B and understanding that they're not saying greater than 7.2, understanding what they're talking about when it comes to the base deficit. But really, regardless of vital signs, what they're asking you is understanding that a resuscitation with a normalized lactate is one of the best indicators. All right. Second question. You have another 48-year-old man who's admitted to the ICU after he underwent an emergency XLAP for multiple small bowel perforations due to abdominal trauma. Over the next 12 hours, he becomes progressively oliguric despite adequate fluid resuscitation, and his vent requirements are increasing. His abdomen appears distended and tense on exam. Oh, I think. Okay. There we go. Tense on exam. His intra-abdominal pressure is measured via transducer attached to a Foley catheter. After instilling 25 mils of sterile saline into the bladder, the pressure at end expiratory in the supine position is recorded at 24. Which of the following is the most appropriate next step in management? A, administer a bolus of IV fluids to optimize organ perfusion. B, increase sedation and neuromuscular blockade to reduce the intra-abdominal pressure. C, obtain an urgent CT scan of the abdomen and pelvis with IV contrast. D, emergent decompressive laparotomy. Or E, place the patient in reverse Trendelenburg to lower intra-abdominal pressure. All right, basically everybody got this question. The question is asking us about compartment syndrome. And the important things to pull out of this question, what seems like mostly everybody got, was that the patient had sustained intra-abdominal pressures above 20, and they also had evidence of end organ dysfunction. And so this patient had what was a pressure of 24, and then they highlight in the question stem that he had adequate fluid resuscitation. And in spite of that, wasn't making urine and his vent settings were going up. So he already had all the signs of organ dysfunction plus the high pressures. All right. A 45-year-old woman with B positive blood type undergoes a liver transplant. The estimated blood loss is 2 liters, and the patient is hypotensive following the surgery. Packed red blood cells are ordered, but the patient accidentally receives a pack of A positive blood. The patient complains of flushing and wheezing. Her vitals are heart rate of 110, blood pressure of 80 over 40, a respiratory rate of 24. After stopping the blood transfusion, what is the next best step in her treatment? Next best step. A, IV steroids. B, normal saline bolus. C, IV antihistamines, D, dialysis, or E, leukocyte reduced blood. Really think about when they put in the STEM next best step. They're really cluing you into what they want you to do. All right. I think we can end the poll here. So what they really are trying to draw your attention to in this one is the fact that what do you need to do with ABO incompatibility when you give the transfusion to the patient with the wrong blood type? And so you want to give them a bunch of fluids and resuscitate them, obviously, after you immediately stop that blood transfusion. Ivy, can you scroll down just a little bit? In this table here, in this explanation is also very helpful. So there's going to be 2 situations where you're going to have blood transfusion reaction, and your management of these is different. And so this is the table that I would pay attention to for this question. One is where what this patient had a hemolytic reaction because of the ABO incompatibility. And so the treatment for that is to immediately stop the transfusion and give a bunch of fluid to try to prevent kidney injury in this situation. The other instance where you could have a blood transfusion reaction is a febrile reaction that is non-hemolytic. Okay. And this typically happens because the recipient is reacting to the white blood cells in that other transfusion. And so the treatment of that is different. You once again stop the transfusion, but then this is when you can give the antihistamines and steroids and epinephrine in that instance. And so the management of these are a little bit different because the mechanism of why the patient is reacting is a little bit different. So just pay attention to that so you guys can answer that one correctly. Okay. Question 4. Reliable methods to differentiate ARDS from cardiogenic pulmonary edema include a CT scan of the chest, B, an echo, C, calculating a P to F ratio, D, a BMP, or E, doing a lavage, doing a bronch and a lavage. There's a little bit discrepancy amongst the group here. Okay, let's see. I think we need to talk about this one a little bit more. So, about half of you answered B, which is correct, and then half or a little over a third answered C, which is calculating the P to F ratio. So, the key in diagnosing ARDS is those bullet points based on the Berlin criteria that Dr. Haskins has almost highlighted there. And so you need to have onset within 1 week of the clinical insult. You're going to see bilateral opacities on your imaging studies that you get. And your respiratory failure, this is what they're really getting at right here, is not explained by cardiac failure or fluid overload. So the patient may still have an abnormal P to F ratio because they're not oxygenating well, but you have to make sure that it's not explained by cardiac failure. And so the best way to do that is the gold standard for that would be to get an echo. All right. A 54-year-old man is in the ICU requiring continuous blood pressure monitoring, and a radial art line is placed. 30 minutes later, the nurse notes that the patient's hand is pale and cool. The pulse ox waveform on the index finger is dampened compared to the baseline. A Doppler exam reveals intact ulnar artery flow, but reduced radial artery flow localized to the catheter site. After the extremity is warmed with a compress, perfusion partially improves. Which of the following best explains this patient's findings? A, thrombosis of the radial artery at the catheter tip. Vasospasm of the radial artery related to the catheter. C, air embolism distal to the catheter. D, compartment syndrome from a forearm hematoma. Or E, distal embolization of plaque during the cannulization. All right, basically everybody got this. This is the answer was B here. Basically, it's just highlighting that the vasospasm can happen from irritation from placing the catheter. And you can tell that it's only vasospasm because things improve once they do a warm compress in this situation. Your flow wouldn't improve or if you had embolization or thrombus in this situation. All right, a 32-year-old man with a pheo is undergoing a lap left adrenalectomy. The case was tenuous as the patient was hypertensive and anesthesia started a nitro infusion, but the operation was successfully completed and the patient was transferred to the ICU off all vasopressors. A few hours later, he is found to be unresponsive. His vitals are a heart rate of 70, a blood pressure of 110/60, a temp of 36.3, respiratory rate of 12, 100% oxygen saturation on 2 liters. His hemoglobin is 9.5, white count is 10.8, and his glucose is 90, and his lactic acid is 3.2. Which of the following treatments is most likely to be helpful? A saline bolus. B, glucagon. C, dialysis. D, hydroxycoalbumin and sodium thiosulfate. Or E, dextrose. They're trying to clue you in a little bit into the pathology and a little bit of what he was treated with in the operating room. What do you think is the most likely etiology of his unresponsiveness? All right. Majority of people have chosen D, which is correct. And so what they're trying to get you to recognize is the cyanide toxicity. I think the important thing when you're reading this stem is to note that they basically tell you that he has normal vital signs at this time. His hemoglobin's fairly normal. His lactic acid is a little elevated, but the other options don't make as much sense. Vitals are normal. You're not going to proceed with fluid resuscitation. Glucagon would be indicated if you thought there was beta blocker overdose. And then they told you his glucose was normal, so you're not going to give him dextrose. So they're really cluing you into what happened to him in the operating room and realizing that he has cyanide toxicity. All right, 22-year-old man is hypotensive after an MVC. MTP is initiated, and on XLAP, he's found to have 3 liters of blood in the abdomen, large liver lax, a grade 4 splenic injury, and small bowel injuries with spillage of the enteric contents. The patient's vitals are as follows. He has a heart rate of 120. His blood pressure is 95 over 50. His oxygen saturation is 99%. He is 35 degrees Celsius. His pH is 7.2, and there's diffuse oozing throughout his abdomen. Which of the following is the best operative treatment? A, splenectomy, hepatophy, intestinal resection left in discontinuity, and primary abdominal closure. B, packing, oversewing the liver lax, splenohorphy, intestinal resection in discontinuity, temporary abdominal closure. C, splenectomy, partial hepatectomy, intestinal resection with an anastomosis, temporary abdominal closure. D, proximal loop ostomy for stool diversion, splenectomy, and angioembolization of the liver. Or E, packing with splenectomy, enterectomy without an anastomosis, and temporary abdominal closure. All right. A lot of people have answered and they got it correct. Everybody's doing well on the trauma questions tonight. What they're cluing you into is that he's experiencing the lethal triad of trauma. He's cold, he's becoming acidotic, he has diffuse oozing throughout his abdomen. And so you need to get him out of the OR quickly. And so you should proceed with packing, taking out his spleen, leaving him in discontinuity. What they're also trying to clue you in with the difference here, which everyone kind of picked up on, is um, you should take out the spleen with that degree of injury where you may be able to just oversew or pack some deep liver lacerations or extensive liver lacerations. All right. Next up, we have a 70-year-old woman who is involved in an MVC. Her injuries include 6 rib fractures and a grade 2 splenic hematoma. How should the family be counseled about her risk of further morbidity and mortality? Epidural is not recommended as it is associated with increased mortality in patients with rib fractures. B, the decreased thoracic muscle associated with aging increases her ability to clear secretions. IS use increases pulmonary complications. D, the number of rib fractures is not correlated with the development of pneumonia. Or E, the mortality rate from rib fractures is correlated with the number of broken ribs in this population. I accidentally X'd out of the whatchamacallit, the poll. You'll have to let me know when a lot of people answer.
Most people have answered, so I'll
Okay, great.
advance.
Great. All right. And it looks like it just popped back up for me, and most people got it right. The answer is E. Most of you have rotated on trauma and realized that in this elderly population, that the number of ribs broken correlates with morbidity and mortality. And obviously, some of the other answers just don't make sense. IS is extremely helpful, and multimodal pain is going to be really essential. We have a lot of MVCs today. Okay, a 32-year-old pregnant woman is brought to the ED after an MVC. She's in her 3rd trimester of pregnancy, approximately 30 weeks gestation. Upon arrival to the ED, she suffers from a cardiac arrest. 2 16-gauge IVs are placed, CPR is initiated, and the patient is rolled to her left side. Which of the following is the next best step in management of the patient? A, continue CPR for a total of 30 minutes. B, began transfusion of type O Rh positive packed RBCs. C, consult OB for assistance in management. D, perform an emergent C-section. Or E, begin a 1-liter bolus of LR. All right. Majority of people also answered D, which is perform an emergent C-section. This patient has arrested in the trauma bay and she's in her third trimester. Uh, TrueLearn notes that you should perform the C-section when the mother is within 4 minutes of arrest. I think the other thing to take from this question is understanding that when you transfuse a pregnant patient, whether it's trauma or not, you should be giving them Rh negative blood. So that's one of the reasons that answer did not make as much sense also. And you're not going to wait for OB. Okay. Um, An 84-year-old woman fell, finally not at MVC, and she hit her head at a sniff. On arrival, her GCS is 7 and she's intubated. She takes apixaban for AFib and amlodipine for hypertension. Which of the following agents should be administered to the patient? Oh, I don't even know how you say this first one. The monoclonal antibody. B, vitamin K. C, FFP. D, recombinant factor 7. And then E, adnexant alpha. So what should you give to reverse her anticoagulation? And this is really just a question of if you've done enough trauma, if you've done enough reversals, you may just know this, but this is just going to come down to memory. All right, most people have answered the correct answer, which is E. Okay. And so, um, understanding and picking up that she's on apixaban and understanding about or how to reverse that in the trauma bay is important. And we can scroll down too to talk about the rest of our reversal agents. Um, Vitamin K would be used for Coumadin, but it wouldn't be used in a life-threatening situation. And so you could use FFP, but that also takes a while. And so, did they mention PCC in here? No. Okay. So basically for this question stem, most of you got this right, most of you knew this, but when you start to think about the other reversal agents before the AB site, you should take a look at each of the anticoagulation agents and understand which one goes with which for life-threatening reversal. All right, a 33-year-old is brought to the trauma bay after MVC. He is hypotensive and altered. He has a GCS of 8. He has a right thigh deformity and severe injury to his face. They could not intubate him due to severe bleeding and poor visualization of the cords. They're gonna an emergent cric is performed, and which of the following is correct in relation to the technique of this procedure for an emergent airway? A, an endotracheal tube should be used. B, the incision should be made inferior to the cricoid cartilage. C, the incision should be made superior to the cricoid cartilage. D, the endotracheal tube should be inserted at least 10 centimeters. And E, an uncuffed endotracheal tube or tracheostomy tube should be used. It is a test-taking trick and tip when you have two question answers that are opposite of each other. You should probably look at those closely. Alrighty, let's see. So the answer is C. Only about half of you guys got that. But as I was noting, it looked like almost everybody answered B or C. So you guys were kind of clued in that maybe something was going on there. And so basically they were just trying to clue you in about where, in relation to the cricoid cartilage, the cricothyroid membrane was, which is superior. And then the other, even if they didn't give you two opposite things, the other answers, inserting the ET tube 10 centimeters would main stem you. You're gonna need a cuff on there to prevent leak, and an 8.0 tube might be too large, so none of those other even made sense. All right. Which of the following accurately reflects current recommendations for management of massive bleeding in patients with an elevated INR? A, the use of a tourniquet to stop life-threatening bleeding from open extremity injuries in pre-surgical setting is not recommended. B, a target blood pressure, target systolic blood pressure of 90 to 100 until major bleeding has been stopped in the initial phase following trauma without brain injury is recommended. C, in the initial management of patients with expected mass hemorrhage, using plasma FFP in a plasma RBC ratio of at least 2 to 1 as needed, or fibrinogen concentrate in packed red blood cells according to hemoglobin level. DTXA should be administered to the bleeding trauma patient within 6 hours after injury. Or E, the early use of PCC for the emergency reversal of vitamin K dependent oral anticoagulants is recommended. So another anticoagulant question here. We kind of hinted at it on our last one. Okay, about half of people have answered. Okay, majority of people got this. There you go. Majority of people got this right. We talked about PCC being used to reverse vitamin K antagonist quickly. FFP would be okay, but you would have to give a large volume and you would have to thaw it. So PCC is going to be quicker. And then the other answers, once again, some of them just did not make any sense, like not using tourniquets. The recommendation for TXA is within 3 hours, and that's just like a little memory thing that you would have to remember for the test, and maybe you use that in real life. All right, last question for our trauma critical care. We have a 33-year-old who's admitted to the ICU after a laparotomy for traumatic injuries to his spleen and diaphragm. He undergoes a temporary abdominal closure and goes to the OR for a second look, or he's going to require a second look laparotomy for fascial closure. Which of the following most likely places this patient at risk for failure of fascial closure at the second look operation? All right, a hernia question. Okay. Return to the OR within 24 hours. Enteral feeding. C, extubation between index and second look laparotomies. D, high volume crystalloid resuscitation. Or E, history of previous abdominal surgery. What places him at risk of failure for fascial closure when you take him back? All right. Looks like everybody pretty much knows this one. Everyone's doing well on the trauma questions. I think we can end the poll for this one. The answer is D, high volume crystalloid resuscitation. Everyone pretty much got that. And I would also add that a bad abthera placement would also put you at risk for not a good fascial closure, make it really tight. But you guys understood all that one. And I don't think we need much explanation for it. All right, I think that's it for trauma critical care.
Dr. Bosley, thank you so much for a phenomenal overview of that topic and for kicking this off this year. Great, great presentation. Thank you so much.
Thanks.
And again, I'm Michael Awad, one of the co-hosts for the program. I'm so excited to have you all here. Thank you all for joining us again for the 11th year. I also want to add my thanks to Gore, our sponsor for this event, as well as for TrueLearn for providing the questions. Just also a note for those of you that may have not discovered this, while we don't have the chat live, we do have a Q&A box that you can use within Zoom. If you have questions that aren't answered live during the webinar, you can put your questions in there, and one of the panelists will do our best to try to answer that promptly. It is now my distinct pleasure to introduce our next panelist, Dr. Amy Rosenbluth, who's a frequent flyer to this webinar. She's a minimally invasive bariatric foregut and general GI surgeon at Stony Brook in New York. A phenomenal teacher in herself, and we brought her back again because of her previous expertise and shepherding us through this webinar. She's going to be leading us in the discussion of breast and endocrine topics this evening. Welcome and thank you, Dr. Rosenbluth.
Thank you so much for that nice introduction. All right, so we are off to breast and endocrine. First question, when compared to women with BRCA2 mutations, women who instead have BRCA1 mutations are more likely to A, have a first-degree male relative with breast cancer, B, develop cancer later in life, C, have a lower risk of ovarian cancer, D, have a lower risk of breast cancer, or E, have triple-negative breast cancer. And while you guys are thinking this one through, I think it's important to know that I think BRCA1 and BRCA2 differentiation questions have shown up on ABSITE basically every year. And so these are some really good things to know when you're differentiating between them. It looks like most of you are pretty confident in your answer. Give it another second. We'll go ahead and end the poll there. So the correct answer is E. So when we're talking about BRCA1 versus BRCA2, male breast cancer is more common with BRCA2. Later in life is more common with BRCA2. Ovarian cancer is more common in BRCA1, so having a lower risk would be BRCA2. They have a pretty equivalent risk of breast cancer overall, and triple-negative breast cancer is more common in BRCA1, so that is why that is E. A 44-year-old woman with a history of left breast DCIS managed with lumpectomy and radiation therapy 11 years ago presents with a new sub-centimeter lateral left breast lesion identified on a screening mammogram. Corneal biopsy is performed and is consistent with recurrent DCIS. She has no palpable lesions or lymphadenopathy. Which of the following is the most appropriate therapy? A, excisional biopsy. B, lumpectomy alone. C, simple mastectomy. D, total mastectomy with sentinel lymph node biopsy. And E, modified radical mastectomy. And again, when we talk about test-taking skills with these questions, most appropriate therapy. So we're not looking for diagnosis, we're looking for treatment. Okay, and it looks like you guys are there, crushing breast so far. So the correct answer is D. So A, as I said, we're looking for treatment. Excisional biopsy is not appropriate. We already have the diagnosis of DCIS. A lumpectomy alone would increase risk of recurrence. Simple mastectomy, without the sentinel lymph node biopsy, once you do the mastectomy, you would be unable to assess for the sentinel lymph nodes. So you would want to do that with this case, even though it is DCIS and not invasive. So you do want to go for the mastectomy and lymph node biopsy, which is answer D. Modified radical mastectomy is not needed for DCIS. And remember, the reason overall that you cannot do regular breast conserving therapy on the recurrent DCIS is that she has already had the radiation, and therefore that would be too much radiation for the chest wall. A 48-year-old woman presents with a 3-month history of progressive swelling and redness of her right breast. She denies fever or systemic symptoms, and she's treated with 2 courses of antibiotics for presumed mastitis without any improvement. The breast is diffusely erythematous and edematous, involving more than a third of the skin with a peau d'orange appearance. Axillary lymph nodes are palpable. Mammogram shows a spiculated mass in the upper outer quadrant of the right breast with associated skin thickening. Which of the following is the most appropriate next step to establish diagnosis? A, repeat trial of broad-spectrum antibiotics. B, core needle biopsy of the breast mass. C, skin punch biopsy to assess dermal lymphatic involvement. D, immediate modified radical mastectomy. E, FNA of the axillary lymph nodes. So again, test taking skills. What is the most appropriate next step to establish diagnosis? So this is not a how do you treat it question. It's how do you figure out what's going on question. And we've got a pretty 50-50 look on the answers, which I did expect for this one. So we can go ahead and end the poll. The answer is core needle biopsy of the breast mass. So I think everyone here kind of realized that this is a question about inflammatory breast cancer. You do not actually need to do a skin punch biopsy to assess for dermal lymphatic involvement. You have a mass seen on your imaging, and so you do want to get a core needle biopsy of that mass to establish your diagnosis. Having the having the dermal lymphatic involvement may be there, may not be there, but is not sufficient for the diagnosis or the management of the disease. A 49-year-old woman presents to the surgery clinic complaining of spontaneous nipple discharge. Exam reveals a unilateral bloody discharge. There is a palpable mass deep in the periareolar area. Image-guided core needle biopsy demonstrates branching fibrovascular core with overlying epithelial and myoepithelial layers with cellular atypia. The next best step in management and diagnosis of this patient is A, lumpectomy with sentinel lymph node biopsy, B, excisional biopsy, C, terminal duct excision, D, simple mastectomy, E, modified radical mastectomy. Another next best step, really key in this question, is understanding what they are describing. And so you do need to know what those keywords are telling you what this diagnosis is. Okay, I think we can probably end the poll there. So the answer here is B, an excisional biopsy. So what they're describing is a papilloma. It was kind of, most of you got B, but there were a large amount of you got C, terminal duct excision. So this is what you would do if you did not have an identified lesion, if you're concerned with papilloma. Because they do have the identified lesion, what you're going to go ahead and do is the excisional biopsy instead. This does have atypia, and that is why you are excising it. A simple mastectomy is not necessary. That would be for malignancy along with a modified radical mastectomy. What are the biologic effects of tamoxifen? A, blocks the conversion of androstenedione to estrone, a weak estrogen antagonist in all tissues, an estrogen agonist in non-breast tissue, but a competitive estrogen antagonist in the breast, a weak estrogen antagonist in non-breast tissue, but a strongly competitive estrogen antagonist in the breast, an estrogen agonist in non-breast tissue, but a non-competitive estrogen antagonist in the breast. So, key to knowing this question's answer is knowing what tamoxifen is and how it works. There's no special tricks to this, although, as we said in prior tests, if questions are or if answer stems are opposite of each other, you do want to pay close attention to that. All right, let's go ahead and end the poll here. Really mixed results with you guys, which I can understand. So tamoxifen is a SERM. Answer A is the description of an aromatase inhibitor. B, saying it's a weak antagonist in all tissue is inaccurate. It is C, it is an agonist in non-breast tissue, but a competitive antagonist in breast tissue. So no way really to get this without just kind of knowing how tamoxifen works. What is the most common biochemical alteration in patients with MEN1 syndrome? A, calcitonin levels, B, prolactin levels, C, calcium levels, D, thyroglobulin levels, E, gastrin levels. So key to this question is knowing the difference between MEN1, MEN2A, and MEN2B, and the most common things that occur with MEN1. All right. So with that, we'll end the poll. Most of you did get this. There is a little bit of a question on A, which I can understand. So A, read the question carefully, both the answers and the stem. So MEN1, calcitonin, not calcium, is what A says, and calcitonin would be associated with medullary thyroid cancer, which is MEN2A. When we're talking about MEN1, the most common issues come from the parathyroid, and so calcium is what you're looking for. While gastrin levels and prolactin levels could be elevated in MEN1, they are not the most common. The most common is parathyroid issues. A 40-year-old man presents with recurrent episodes of symptomatic hypoglycemia that improves with ingestion of glucose. After further workup, he's found to have a 1.5 centimeter insulinoma in the distal pancreas. During laparoscopic enucleation of the mass, the surgeon struggles to find it, even after using intra-op laparoscopic ultrasound. What adjunct test is helpful in assessing successful insulinoma excision? A. Contrast-enhanced ultrasound. B. Conversion to open for manual palpation. C. Monitoring the insulin to glucose ratio. D. Endoscopic ultrasound. E. Angiography and arterial stimulation venous sampling. Again, pay close attention to the question's stem, which is asking you about excision, not about how you find it. Okay, we'll go ahead and end that there. So, most of you did get this, but there were a couple answers all over. So again, when I say looking for excision, this is testing to make sure you've got the whole mass out, not finding the mass during surgery, actually, as the question stem would make it seem. So even if it was for that, when we're talking about these, a contrast-enhanced ultrasound helps with vascular, and so that would not be helpful with this. Conversion for open is not necessary. Endoscopic ultrasound would be difficult to do in the middle of the case, so would the angiography with arterial stimulation. Monitoring the insulin to glucose ratio is the correct answer. You would see it being greater than 10 if the insulinoma is there, and once it is removed, it should drop to less than 6. Okay. A 25-year-old man presents with a distal radius fracture, elevated serum calcium, and low serum phosphate. He takes no medications. Surgical history is significant for a subtotal parathyroidectomy for parathyroid hyperplasia with foregland involvement, after which he was lost to follow-up. What is the most likely diagnosis? A. Recurrent sporadic hyperparathyroidism. B. Recurrent hyperparathyroidism secondary to MEN1. C. Secondary hyperparathyroidism. D. Tertiary hyperparathyroidism. Or E. Medication supplementation. All right, I think we can pause those questions there. So most of you did get this, which is B. When we're talking about hyperparathyroid or parathyroid hyperplasia in a 25-year-old, that would be pretty uncommon, and so you should already be clued into the possibility of MEN1. To have it recur, especially again, we're talking about a young man at 25, that would be very uncommon. So that is why A is wrong. Secondary hyperparathyroidism is not what the question stem is describing. It's describing primary, and tertiary is the result of a long-term secondary. So again, not the description. A 42-year-old woman presents to the emergency department with abdominal pain. She has no past medical history, but reports new stretch marks on her abdomen, weight gain, easy bruising, and recent depression. A 24-hour urine cortisol level is elevated. Plasma ACTH is depressed. A high-dose dexamethasone suppression test fails to suppress cortisol levels, and a CT scan shows an 11.3 centimeter right adrenal adenoma without clear fat planes. There is no local or regional lymphadenopathy. What is the next best step in management? A. Observation. B. MRI of the abdomen. C. Unilateral laparoscopic adrenal resection. D. Open unilateral adrenalectomy. Or E. Open bilateral adrenalectomy. Again, this is a next best step in management question. All right, we can end it there. It looks like most of you got this. This is open. So observation is wrong. You've got a functional tumor. MRI is wrong. You already have its location. There's no need for an MRI. The reason laparoscopic is incorrect is that this is an extremely large tumor at 11.3 centimeters, so anything over 6 is recommended to be open, and you certainly don't need to do bilateral for this. A 38-year-old woman is undergoing left laparoscopic adrenalectomy for a phiochromocytoma. After induction of anesthesia, the patient's blood pressure rises to 210 over 177 with sinus tachycardia. She had received appropriate pre-op medications. Which of the following is the next best step in managing this patient? A, performing urgent XLAP to ligate the left adrenal vein. B, start esmolol. C, start nitroprusside. D, administer IV lidocaine. E, increase the dose of inhaled SIBO. It does look like most of you are getting this question as well, so great job. Just to go over a couple of these, you don't need to do an XLAP. You need to manage the emergent hypertension. She has already been alpha blocked and beta blocked, given that they said she had the appropriate management, so esmolol is not correct. Nitroprusside is a quick on, quick off medication, and so this would be your best option intra-op. IV lidocaine is for arrhythmias, and SIBO, which is her anesthetic, is not going to solve the emergent hypertension. A 52-year-old female presents to the emergency room with a complaint of abdominal pain and 30-pound weight loss. She undergoes a CT scan, which finds a 6.2 centimeter adrenal mass with loss of fat planes and retroperitoneal lymphadenopathy, suggesting a locally invasive malignancy. She undergoes a full workup and is scheduled for en-bloc adrenalectomy. What is the most important predictor of survival for adrenal carcinoma? A, adequacy of resection. B, number of lymph nodes sampled. C, number of lymph nodes positive. D, local invasion. E, response to chemotherapy. All right, and we can end it there. Looks like most of you have answered. So a little more question on this. Most of you did get it, but the answer is A, adequacy of resection. Lymph nodes are and local invasion are, of course, with most cancers concerning for survival. However, with most cancers, if you are resecting, the R0 is what you're going for, and an R1 is a very poor predictive factor. So just the same adequacy of resection is the most important. A 32-year-old woman comes into the clinic for evaluation of an enlarging palpable mass in her right breast. On examining the patient, you note a solitary rubbery mobile mass with smooth round edges. Ultrasound of the mass suggests a size of approximately 6 centimeters in diameter with both solid and cystic characteristics. FNA in the clinic yields data showing epithelial and connective tissue components. A phylloides tumor is suspected. Which of the following is true of this disease? A, like a fibroadenoma, it is a benign entity requiring observation only. B, characterized based on cellular atypia, mitotic activity, and stromal overgrowth. C, metastatic disease predominantly disseminates through lymphatic channels. D, adjuvant chemo reduces local recurrence. And E, recommended margins are 2 centimeters. So there's no real trick to this question or test taking skills for it. You do just sort of have to know about phylloides tumors. And we can go ahead and end the poll there. Most of you did get this. So phylloides tumors are characterized based on cellular atypia, mitotic activity, and stromal overgrowth on a spectrum of benign to malignant. So A is wrong. They are not necessarily always benign. They are disseminated hematogenously, not lymphatic. The recommended margins are actually 1 centimeter, just so you guys know. But this is the stem in this actually doesn't really contribute. Basically, you just need to know what is true of phyllodes.
All right, we are cruising right along. Thank you, Dr. Rosenbluth, for your expertise and for being back with us again this year. I'm going to go ahead and introduce our next speaker, and then I will pull up the questions. So returning again this year is Dr. Vipul Khetarpaul. He is an associate professor of surgery at the Washington University in St. Louis. And we are so grateful that you could join us again this year. He is a longtime veteran for the SAGES general surgery webinars. And his expertise in vascular surgery is so appreciated. Dr. Awad recruited him when we first started this. So thank you again, Vipul, for being with us again this year.
Thank you very much for having me. So let's jump straight into the vascular questions, which is everyone's favorite on this webinar. So we again have a set of 12 questions that we'll go through. First question is 75-year-old man with ESRD is expected to be started on dialysis. The nephrologist refers to the vascular surgeon for creation of an AV fistula. Which of the following is true regarding creation of AV fistula? A, prosthetic access is preferred over autogenous access. B, a pulsatile signal at the end of creation of an AV fistula indicates good flow. C, rule of three criteria is used to assess maturation prior to cannulation. D, a side-to-side anastomosis has better patency rates. Or E, adequate diameter of artery is greater than 2 millimeters, and for vein, it is greater than 3 millimeters. I think we can end the poll right here. Majority of you have gotten this question correct. So essentially for dialysis access, you want to pick a healthy artery that's at least greater than 2 millimeters in diameter, and your vein greater than 3 millimeters gives you the best predictive value for how the fistula is going to perform. Once the fistula is created, if you have a thrill, that indicates higher odds of maturation compared to a very pulsatile flow, which indicates outflow obstruction. The rule of three is actually a rule of six, that the vein diameter has to be over 6 millimeters, depth less than 6 millimeters, and flow greater than 600 ml per minute for a length of 10 centimeters for a maturation criteria. And in terms of anastomosis, enticide generally has better patency. Next question, please. A 25-year-old pitcher presents with acute swelling of right upper extremity. He has no past medical history and has palpable pulses in his wrist. What is the most likely cause of his arm swelling? A, embolus. B, chronic injury to axillary and subclavian vein. C, occlusion of SVC. D, cervical rib. E, acute compression of axillary and subclavian vein. All right. So the correct answer is B. So essentially, they're asking about venous thoracic outlet syndrome. So repeated trauma, as there is more and more overhead activity of the arm in a pitcher, leading to repeated trauma at the axillary and subclavian vein at the thoracic outlet. So this does not, sudden arm swelling obviously means some form of a venous obstruction, so an acute DVT, but the underlying culprit in the acute DVT is chronic scarring of the vein with repeated trauma at the level of the thoracic outlet. While cervical ribs can contribute to it, it is not necessary to have cervical rib as a part of this pathology. It is not an SVC syndrome because that's not how it presents. You'll have a lot of face and eye and swelling of airways, etc. with that. This is not an acute compression of axillary subclavian vein. This is somewhat of a more chronic, repetitive interaction of the thoracic outlet with the vein, leading to internal scarring, making them more prone for thrombosis. Thoracic outlet is very high yield for the ABSITE exam. So you would want to know everything about thoracic outlet, including the anatomy of the thoracic outlet and how it's treated. Next question. A 52-year-old man with a history of 4.2 intrarenal AAA presents to the ER with a pulsatile mass in right groin. He denies any history of catheterization of femoral arteries. He's hemodynamically stable. On exam, he has a 3-centimeter pulsatile mass with palpable popliteal DP and PT pulses. His strength and sensation of the extremity are intact, and his creatinine level is twice his normal baseline at 2.2 milligram per deciliter. What is the next best step in management of this patient? A, observation, B, duplex, C, CTA, D, MRA, or E, conventional DSA. All right. So I think a lot of you got this question correct. So the next best step in a patient with acute kidney injury with a creatinine of 2.2 with a pulsatile mass is a duplex ultrasound, which is a non-invasive way of understanding what this pulsatile mass is. In a patient with AAA, they're more prone to have aneurysms in other locations, including common femoral artery, popliteal artery, etc. And duplex would be the next best step in establishing what kind of pulsatile mass this is, which is likely going to be a femoral aneurysm in absence of any previous interventions. You would not want to do a CTA in this circumstance with elevated creatinine, and obviously a DSA would require catheterization, which would be again invasive and make his kidney function worse. Next question. 69-year-old man underwent a left fem-pop bypass with prosthetic graft 2 years ago. He did not return for follow-up and presents now with a small sinus tract within the left groin close to the proximal anastomosis. An arterial duplex demonstrates a pseudoaneurysm at the proximal anastomosis. You suspect that the patient has a graft infection. However, your initial blood cultures are negative. What is the most likely microorganisms causing this clinical setting? A, Staph epidermidis, B, Staph aureus, C, E. coli, D, Propionibacterium avidum, or E, Pseudomonas. So essentially, 2 years later, after a prosthetic bypass, a sinus tract and a pseudoaneurysm. All right. So about 60% of you got the question correct, which is Staph epidermidis. So when people have acute post-operative infections, they're generally from organisms which have a higher virulence. For example, Staph aureus. So if somebody got a severe infection of the groin, say 5 days out, 7 days out, something like that, you would suspect either a gram-negative or a Staph aureus kind of infection. Oftentimes, blood cultures would be positive. There could be systemic signs of being sick or septic. And these infections with Staph aureus or Pseudomonas or gram-negatives generally are pretty devastating. They can eat away at the soft tissue. They can eat away at the grafts and the arteries, that even the native vessels. Even in circumstances where we use bovine patches, etc., they're not immune to these infections a lot of times. When people have a delayed infection, say 4 months, 6 months out, generally it is an organism with low virulence that does not pop up as a positive blood culture, and most commonly a skin contaminant like a Staph epidermidis is the underlying organism for those infections, like in this case. Next question. 47-year-old man with history of renal transplant 5 years ago for ESRD secondary to diabetes presents with painful chronic wound on his leg. The lesion is ulcerated with necrotic areas, as well as purple colored mottling of skin and induration in a livedo reticularis pattern. His creatinine clearance has been decreasing over the past year. What is the most likely diagnosis? So this is the patient's wound on his thigh, it looks like. Post-transplant proliferative disorder, B, calciphylaxis, C, sarcoidosis, D, melanoma, E, basal cell carcinoma. All right. So majority of you got this question correct. This is a very typical lesion for calciphylaxis, which is a devastating, oftentimes fatal problem seen in ESRD patients. The underlying pathophysiology is not very well understood, but we know that it affects a small minority of patients with ESRD, where this lesion typically with these dark edges and livedo reticularis pattern emerges. We keep on debriding them and all the skin and soft tissue keeps on dying back. Extremely difficult to treat, but easily diagnosed based on this physical appearance, and biopsy is very typical. If you do a skin biopsy, you can find out very quickly what the underlying cause is. Next question. 29-year-old mountain climber falls and sustains multiple injuries, including tibial plateau fracture. His life-threatening injuries are successfully treated, he's on a vent. You're called by his nurse post-op to evaluate calf swelling on the side of the patient's fracture. He is currently sedated and non-responsive to stimuli. The calf is swollen and appears to be tense. What is the most appropriate next step in his evaluation? A, nerve conduction study, B, CT of lower extremity, C, ABI, D, perform fasciotomies, E, venous duplex of the lower extremity. All right, let's see the answer. The correct answer is perform fasciotomies. So this is a clinical scenario. Somebody with polytrauma, tibial plateau fracture, with tibial plateau fracture, high incidence of vascular injuries, but also it's a tight space where you can easily have compartment syndrome. So same leg as the tibial plateau fracture that is tense in the acute phase is more likely than not a compartment syndrome, especially in a patient where they're not able to give you a sound exam, very low threshold for performing fasciotomy for further diagnosis. A 27-year-old man with neurogenic TOS that failed conservative management is scheduled to undergo a right thoracic outlet decompression. During the inferior dissection of the anterior scalene muscle, the field is flooded with blood welling up from the anterior aspect of the anterior scalene muscle. Which of the following has likely been injured? A, right subclavian artery, B, right subclavian vein, C, right external jugular vein, D, right axillary artery, or E, right middle thyroid vein. All right, we can stop right there. Majority of you got this question correct. So again, this is an anatomy question. So scalene triangle in thoracic outlet between the anterior scalene muscle, the middle scalene muscle, and inferiorly the clavicle, you generally have your subclavian artery and your plexus running through. And anterior and medial to your anterior scalene muscle, generally you have the subclavian vein running through. So the injury has been described along the anterior aspect of the anterior scalene muscle, which is where the vein would sit. So most likely injury would be to the vein. Next question. 54-year-old right-handed man with ESRD secondary to severe hypertension and diabetes is referred to your office for hemodialysis access and undergoes a left brachiocephalic AV fistula creation. 9 weeks post-op, he presents with significant progressive left hand pain. He has a diminished left radial pulse that enhances with fistula compression. Duplex of the fistula reveals normal access flow rates. What is the most appropriate next step in his management? A, banding or a flow limiting procedure. B, revision using distal inflow. C, proximalization of arterial inflow. D, distal revascularization, interval ligation, or E, distal radial artery ligation. All right, so majority of you were split between A and D, and the correct answer is D. So this one requires a little bit of thought process. So they're describing a patient with essentially a steal syndrome. So the axis is stealing too much flow away from the remaining arterial, circulation of that extremity about 9 to 10 weeks out. So a little bit chronic phase, not just in the acute phase. In this individual, they did the ultrasound and that showed normal access flow rates. So if the flow rate is normal, so for example, it's only 600 ml per minute, which is the bare minimum for the access to be functional. If you were to band it, it's not going to solve your problem because you limit the flow any further, the fistula is not going to work. You might as well ligate it, right? So in this circumstance, the best option with good data supporting patency of access and still improving their steal symptoms is distal revascularization and interval ligation, provided they have a good autogenous vein, like a greater saphenous vein, to perform the intervention. And essentially what they do is we do a bypass from the brachial artery 5 centimeters away, proximal to the AV anastomosis, and plug it into the brachial artery beyond AV anastomosis and ligate the brachial artery just distal to where the AV anastomosis is. And it proximalizes the arterial inflow for the remaining hand before feeding into the fistula. So very important. So this figure right here is extremely important to understand. The remaining, options that are available, for example, revision using distal inflow, that is again done in cases where they have a high flow access. So by taking inflow from a smaller artery further down distal, they're dropping the flow in the axis and reducing their steal. Proximalization of arterial inflow can help in normal flow access, and you're essentially taking a prosthetic graft from, say, a higher caliber vessel like the axillary artery and plugging that into your access. But the results are kind of variable and not always consistent, so it's oftentimes not used. Distal radial artery ligation is uniquely done only for one specific circumstance where a patient has a radiocephalic AV fistula that is pulling flow from the palmar arch, from the ulnar and causing hand ischemia, in which case we tie off the artery distal so it does not keep on pulling flow from the fingers. Next question. 24-year-old man presents following a high-speed motorcycle accident. A CT with IV contrast shows a left first rib fracture, a left mid-clavicle fracture, and a left hemothorax. A left subclavian artery injury is suspected. Which of the following is the best option for obtaining proximal and distal control and repair? A, median sternotomy. B, left posterior lateral thoracotomy with separate left supraclavicular incision. C, left anterior lateral thoracotomy with separate left supraclavicular incision. D, left deltopectoral incision. E, transsternal bilateral anterior thoracotomy. So this question is very commonly tested on the exam. We'll go to the answer. The correct answer is C. So we generally, you have to understand how to approach the proximal aortic arch injuries from a trauma standpoint. So if you had a proximal right subclavian artery, or sorry, innominate artery injury or a left carotid injury, the best way to reach the origins of these vessels is through a median sternotomy. The arch generally dips anterior to posterior. So if you were to just do a median sternotomy, you would not be able to get to the left subclavian artery origin very easily, which is best dissected or exposed with a anterior lateral thoracotomy. Generally, for arch or proximal arch branch injuries, posterior lateral thoracotomy does not give you the exposure that you need. And like I mentioned earlier, median sternotomy is great for innominate and left carotid artery injuries proximally, but not the left subclavian. Next question. A 61-year-old male is found to have rectal bleeding 2 days after an open AAA. On exam, the patient is febrile and has abdominal tenderness and distension. His white cell count is mildly elevated, but he remains hemodynamically stable. What is the best next step to manage this patient? A, urgent CT scan with oral and rectal contrast. B, serial abdominal exam. C, sigmoidoscopy. D, abdominal plain films. E, emergent re-exploration. All right. So most of you got this question correct. The correct answer is C, sigmoidoscopy. Essentially, the very common scenario tested in general surgery. This was actually my oral board STEM for vascular component when I was taking the test. Major complication of AAA repair where IMA is taken as a part of the AAA repair with poor collateralization, or there are post-operative significant fluid shifts, hypertension, etc., resulting in uh, watershed ischemia of the sigmoid colon. So some of you answered an urgent CT scan. Even if you were to get an urgent CT scan, you would not want any rectal contrast to be pushed up in an ischemic sigmoid colon, which could result in perforations. So out of these options, the best option appears to be sigmoidoscopy, which will let you know if it's a partial thickness problem or a full thickness issue that requires emergent exploration and then colectomy. If it's partial thickness, then you can buy yourself some time with antibiotics, hydration, and expected management, and watch for further deterioration or improvement. Next question. Which site has the longest patency after angioplasty? A, superficial femoral artery. B, iliac artery. C, popliteal artery. D, common femoral artery. Or E, tibial artery. All right, let's see the answer. The correct answer is B, iliac artery. So generally, balloon angioplasty in the iliac segment has a patency of 75% at 5-year mark. As the caliber of the vessel keeps on going down, the odds of restenosis and reocclusion of these vessels keeps on going up. For example, for a tibial vessel, which is the smallest of the group, the patency rate at 3-month mark is 60%. So just notice this. For an iliac artery at 5 years, the patency rate is 75%. We're talking about a 5-year horizon here. And as you go down to the smallest vessels like the tibial arteries, you're now looking at weeks to months in terms of patency. If you go down further into the pedal segment, the patency rate even drops further. Next question. So this is the last vascular question. 63-year-old, otherwise healthy female was recently diagnosed with severe uncontrolled hypertension, and the diagnostic workup reveals an underlying renal artery occlusion. Which of the following is correct regarding the types of renal artery occlusive disease? A, atherosclerosis is the most common underlying pathology. B, medial fibroplasia occurs exclusively in males. C, perimedial dysplasia is most common diagnosed dysplastic renal artery disease. D, intimal fibroplasia occurs more commonly in the elderly. Or E, developmental renal artery disease usually occurs distally. I think most of you got this question correct. So the correct answer is atherosclerotic disease, which is the most common macrovascular occlusive disease affecting renal arteries. Second most common type of renal artery disease is fibrodysplasia, FMD, which is most commonly medial fibroplasia, not perimedial dysplasia. It happens more often in women than men, and the underlying um, developmental renal artery disease is extremely rare and oftentimes coincides with coarctation of aorta and is oftentimes diagnosed early. So that's the rarest of this bunch. Thank you. I think that concludes the vascular component.
Vipul, thank you very much for once again joining us this year and gracing us with your expertise on this topic. It's been phenomenal as usual. So thank you very much. Greatly appreciated.
Thank you for having
And
me.
thank you. And as we transition to our last speaker, I'd like to encourage folks to hang on after Dr. Hennessy's presentation for some important concluding announcements and remarks by Dr. Haskins. But now it is again my distinct pleasure to once again welcome back Dr. Sara Hennessy. Dr. Hennessy is again another frequent flyer to this session, invited back because of her phenomenal shepherding of these questions and her expertise. Dr. Hennessy is a minimally invasive foregut bariatric and general surgeon and director of the surgical intensive care unit at UT Southwestern. Been in practice for over 10 years and is also the recipient of the Sages Barbara Bursey Memorial Leadership Award. Dr. Hennessy, thank you so much for coming back and joining us again. Dr. Hennessy is going to lead us in the discussion of a variety of ABSITE topics in what we call the miscellaneous category. Welcome back.
Thank you so much. I have the distinct pleasure of having the potpourri session. So you guys are going to get a wide variety of questions. So just stick with us through it. I think these are pretty high yield questions given they're kind of all over the place. So the first question is a 6-month-old male is brought by his mother to the pediatric surgery clinic due to a right testicular enlargement that presents since birth. The mother states that the mass increases in size during the day while the child is upright and decreases in size overnight while the child is supine. On examination, there is a non-tender cystic swelling of the scrotum that surrounds the testicle, and transillumination is evident. What is the best treatment of this child's problem? A, observation, B, hydrocelectomy, C, high ligation of patent processus vaginalis, D, herniography, E, orchopexy. And I don't see the poll yet. There we go. Okay. Sorry, I didn't see it come up on my screen, Dr. Awad. So if it doesn't keep popping up, you might have to tell me when it seems like most people have answered.
No problem. I think you're good now. It looks like most people answered C, about 43%, and 36% answered A.
Okay, perfect. So kind of almost a split here. And the answer is C, high ligation of the patent processus vaginalis. And what this question is really getting at with the testicular swelling increasing and decreasing in size and the transillumination, or the scrotal swelling, sorry, increasing and decreasing in size and the transillumination, is that this is a hydrocele that has communication. And so the treatment for communicating hydrocele is high ligation of the patent processus vaginalis, and that is the anatomical reason why these children have that fluctuation in the fluid and that there is communication. If this was an inguinal hernia, which it is not, then the answer would be D. The other selection that most people made was A, observation, which would be true if this was a non-communicating hydrocele. And most of these go away in the first year or two of life. But in that situation, it would not be increasing and decreasing in size. So that's the key there, to let you know that it is a communicating one and therefore needs intervention. Your second patient is a 3-year-old who presents 6 hours after witness ingestion of a nickel. The child is well appearing, tolerating secretions, and in no respiratory distress. Chest x-ray on arrival demonstrates a coin-shaped foreign body lodged in the distal esophagus at the GE junction. A repeat x-ray performed 12 hours later shows the foreign body in the same location with no evidence of distal progression. The patient continues to be asymptomatic during this period of time without any signs of perforation or airway compromise. What is the most appropriate next step in management? A, direct laryngoscopy under general anesthesia. B, exploratory laparotomy under general anesthesia. C, observation. D, flexible endoscopy under conscious sedation. And then E, flexible endoscopy under general anesthesia. Again, I'm not sure when most people have answered because it's not popping up for me, but
So
We'll give a
most
couple
people
of
have answered.
seconds. Oh, sorry. Go ahead, Dr.
Nope, go
Hennessy.
ahead. Go ahead. It's okay.
It looks like we got about half of the participants, and 82% answered E. And Dr. Hennessy, you might also try clicking the polls/quizzes button at the bottom of your Zoom screen. But please proceed.
okay. Okay, so most people answered E, which is correct, flexible endoscopy under general anesthesia. Oh, I'm sorry, I lost the screen. Do you all see it?
Can you see it now?
Okay, yes. So E, flexible endoscopy under general anesthesia. What this question is really getting at is one, identifying whether or not the child's ingestion is a airway ingestion or a GI tract ingestion. Once you've differentiated that with which clearly, if the X-ray shows it at the level of the G junction, this is not in the airway. That first picture that you see in the answers for A demonstrates a coin that's stuck at the carina. This scenario, that coin is much lower at the level of the diaphragm. And then the laparotomy is inappropriate here because the child is not having peritonitis or any instability. And then the decision between conscious sedation and general anesthesia, the answer in any foreign body ingestion is always going to be general anesthesia because of the risk of compromise to the airway, but also just general comfort for the child to have this done under general anesthesia rather than conscious sedation. But that I would say is true even in an adult. If you're performing a flexible endoscopy for foreign body removal, those cases are always safer to be done under general anesthesia to help protect the airway. Okay, your next patient is a 6-week-old infant who presents to the pediatric emergency department with multiple episodes of projectile non-bilious vomiting. An olive mass is palpated on abdominal exam. Based on the phoretic Ramstead technique, which layer of the gastric wall should be visualized to ensure the procedure's success? A. Serosa, B. Muscularis propria, C. Muscularis mucosa, D. Circular muscle layer, E. Mucosa.
Dr. Hennessy, are you able to see the polls as of yet?
Now it just popped up for me,
Okay,
so
terrific. It looks like most have responded.
yes. So the answer for this question is E, mucosa. And this obviously represents a question getting at pyloric stenosis and what is the most appropriate operative intervention, which is a pyloromyotomy. When you make your pyloromyotomy, you make a longitudinal serosal incision on the anterior superior aspect of that pylorus, just a millimeter or two proximal to the duodenum. And what you're really wanting to get towards is that that muscle layer. And so as you make your incision through the serosa, you want to go through your muscle layers and the submucosa, and you want to see that mucosa bulging out of your incision, which demonstrates that you've completed the pyloromyotomy. You obviously don't want to see the mucosa itself. That means that you performed a full thickness incision, but that mucosa bulging is the key here, and that's the answer E. Your next patient or question is, which of the following best describes the embryological defect in omphalocele?
And Dr. Hennessy, if you could please read the responses for those who
Oh,
may
I
not
am
be.
so
Yeah,
sorry. I
thank
got
you.
distracted. I appreciate it. A, persistent omphalomesenteric duct. B, weakness of the umbilical membrane at the site of the right umbilical vein reabsorption. C, incomplete closure of the anterior abdominal wall at the umbilicus. D, weakness at the umbilical ring. And E, persistent patent processus vaginalis. It looks like we're about halfway through. Okay, so the correct answer here is C, which seems like most everybody chose. Um, Incomplete closure of the anterior abdominal wall at the umbilicus, and that is the cause of an omphalocele. Remember that a persistent omphalomesenteric duct represents a Meckel's diverticulum, and that is the embryological defect that leads to that finding. The gastroschisis is what is caused or a result of a weakness of the umbilical membrane at the site of the right umbilical vein reabsorption. And then a weakness of the umbilical ring is really representing umbilical hernia at birth. And then lastly, the persistent patent processus vaginalis indicates an indirect inguinal hernia. Your next question is a 58-year-old man underwent a heart transplant 5 years ago. He now presents with recurrent heart failure with a left ventricular ejection fraction of 25%. He undergoes cardiac catheterization, which shows diffuse stenosis of his coronary arteries without calcification. Which of the following is the most definitive treatment for this patient? A, percutaneous coronary intervention. B, multivessel coronary artery bypass grafting. C, left ventricular assist device. D, cardiac retransplantation. And E, start anticoagulation. Okay, we're about halfway. A little bit of a split here between B and C. The answer is D, which is cardiac retransplantation. So here, obviously, we've switched from peds to transplant questions, but uh, the finding of vascular disease in the coronary arteries after heart transplant indicates vasculopathy, which is often a complication that's seen 1 to a few years out from transplantation, and can be caused certainly from rejection. And so it's one of the indicators actually for retransplantation. Um, the other answers, which are PCI and cabbage, essentially, are not good options for this because of the severe multivessel disease and how extensive the disease process is. Um, Anticoagulation is really not going to address revascularization. And the real answer here, rather than an LVAD, is relisting the patient for another heart transplant. Very common complication. Your next patient, which of the following will improve the statistical power of a study? I know this is a really tough one that gets a lot of us, including myself. I have to put a lot of thought into it. So the options are exclusion of confounding variables, B, decreasing the magnitude of the difference between the groups, C, randomization, D, lowering the standard error of the mean, and E, decreasing the sample size. And you'll certainly get some sort of statistical question on the app site. I think it happens every year to make sure they have a good understanding of this concept. Well, it looks like we're getting close to about half of the folks answering. So the correct answer is D, lowering the standard error of the mean. When we're talking about power in statistics, the question of power is really the ability to detect a difference between the two groups when a difference actually exists. And the power is directly related to the amount of difference between the two groups that you want to detect. And that's really based on the sample size of the population that you're using and the standard error of the mean. And so when you're looking at these options to kind of decide, what's the right answer, decreasing your sample size and decreasing the magnitude of the difference between the two groups really decreases your power. Increasing your sample size and increasing the difference that you want to see helps improve your power. Exclusion of confounding variables is not really going to affect power. It's going to affect bias. And the answer here that helps improve your power is lowering the standard error of the mean. And then let's see, with randomization, this also doesn't affect power. It will improve the quality of the study that you're doing and will decrease bias between your two groups, but has no impact on power. Okay, the next question here, back to transplant. A 55-year-old woman presents after a recent kidney transplant with a cough, pleuritic chest pain, and fevers. After workup, pulmonary histopathology and culture samples confirm a most common fungal invasive infection of immunocompromised patients. The most appropriate treatment for this patient includes A, resection of the infected tissue, B, voriconazole twice daily, C, itraconazole 3 times daily, D, inhibition of cell wall glucan cross-linking, or E, complete cessation of immunosuppression medications. So, as you're picking your answers here, and when you get these types of questions, I think the key things to remember, which I think has been said before, is to think about what the most appropriate treatment is. Not that, there can't be a time when something different is done, but generally speaking, in this patient population, what's the best answer? Looks like we've got about half of everybody that's answered so far, kind of a split between B, C, and D. Okay, the correct answer here is voriconazole twice daily. The most common invasive fungal infection in immunocompromised patients is invasive aspergillosis. And so this patient had a kidney transplant, kind of presents with these pulmonary symptoms, and it has pulmonary invasive aspergillosis. When you're thinking about these questions, certainly if you had an aspergilloma or like a fungal abscess of the lung, then a resection of that infected tissue is appropriate. But we're talking about a general pulmonary infection, not an abscess of a specific lobe. So that's why surgical intervention is not correct. And then when you're looking at treatment with voriconazole versus itraconazole, it's just important to know that the true treatment for aspergillosis is voriconazole, and itraconazole treats histoplasmosis. So knowing the difference between those two infections and how they present will help you make that decision. Stopping all immunosuppression is inappropriate. Now, decreasing might be appropriate in the setting of an acute infection, but complete cessation of all immunosuppression drugs obviously puts that patient at high risk for acute rejection, especially given the fact that it's a recent kidney transplant. And then the inhibition, of the cell wall glucan cross-linking is really getting at echinocandins, and that's how mycofungin works to treat fungal infections, which is not appropriate for aspergillosis. A tough question, certainly. This is really kind of understanding, one, what the infection is, and most commonly found in immunocompromised patients, and then two, really knowing what the appropriate antimicrobial is for that infection. Your next question is a 64-year-old woman, a status post-kidney transplant. At 8 weeks post-transplant, she was hospitalized and treated for severe acute rejection. She is now receiving maintenance immunosuppressive therapy. For the past several days, she has had a rhythmic involuntary movement of her bilateral upper extremities. Which of the following medications is most likely responsible for her new complaint? A, corticosteroids, B, azithromycin, C, mycophenolate, D, sirolimus, E, tacrolimus. When you're thinking about this question, I think it's important to think back on your experiences with transplant patients and on that service, if you've rotated through it, to know what one are the most common immunosuppressive medications used in kidney transplant patients, and what is the side effect profile of these medications, and recognize that this patient first got it treated for acute rejection and is now on her maintenance medications. So it looks like we've got most people have picked E, which is tacrolimus, which is the correct answer. Knowing the side effect profile of tacrolimus is really important. It's a very commonly used immunosuppression medication. And we most commonly see neurotoxicity with that, and patients will present with headaches, confusion, tremors, and seizures. And so that is how this patient is presenting. I know steroids are often used for acute rejection, but with steroids, the most common side effects that we see are kind of changes in weight and appetite, but you also see hyperglycemia and hypertension and increased risk of infections, which all of these medications do, but that's most often what we see with high-dose steroids. With mycophenolate, which is basically CellCept, GI side effects are the most common for patients: nausea, vomiting, diarrhea, and general GI discomfort and inability to eat is what you see with that medication. And then Imuran or azithromycin, it causes a lot of bone marrow suppression, and so you'll see leukopenia with this medication. That's very common. The other thing to remember about tacrolimus is, other than the neurologic side effects, you'll often see an AKI in this patient population. So you'll have nephrotoxicity, you'll have high blood pressure, and you can have electrolyte abnormalities as well. So most often you'll see more than one side effect profile with that medication. Okay, question number 9. A 56-year-old man with a history of smoking presents to his primary care physician with weight loss, left shoulder pain, numbness that radiates down the medial aspect of the arm into the 4th and 5th digits. On physical examination, he is found to have left-sided facial flushing as well as unilateral meiosis. Workup with the CT scan of the chest, abdomen, and pelvis confirms the presence of a 6-centimeter left-sided apical thorax mass. Diagnosis is confirmed with a transthoracic percutaneous core needle biopsy. Further staging is completed with bronchoscopy, endobronchial ultrasound, and PET-CT, which shows evidence of a left-sided mediastinal and supraclavicular lymph node involvement. What is the most appropriate next step in the management of this patient? A, surgical resection; B, radiation therapy; C, chemotherapy; D, chemoradiation; and then E, immunotherapy. So as you're answering these kind of long stem questions, I would recommend really breaking it down to focus on the key elements, and not losing sight of the details. So here the patient is presenting with a mass, and so the key things are: where is the mass? Is there evidence of advanced disease? What the staging was done to work it up, and then now what is the treatment, most appropriate treatment for this 56-year-old? So it looks like we're almost halfway. Looks like most people are picking D, with some of A, B, and C. Okay, so the correct answer here is D, chemoradiation. This scenario that they're presenting represents a Pancoast tumor, which is a non-small cell lung cancer. These present often in a non-resectable way. They present at the apex. Even if you don't know that this is a Pancoast tumor or didn't remember that, I think the key things that you're hearing is that it's a 6-centimeter mass on the left side, that there's advanced disease with lymph nodes that are positive, and so you have to develop kind of the next best decision in terms of treatment. But with a Pancoast tumor, remember, given where it grows, it often presents with shoulder pain, paresthesias in the ulnar distribution, and Horner's syndrome, which was that meiosis and facial flushing that they described in the presentation of the patient. Because these often present locally advanced, they all need neoadjuvant chemo radiation. Very few of these are surgically resectable. If they are surgically resectable, then they're an appropriate surgical candidate, then they can go on to surgery, but they always have to get chemoradiation first. So that's why A is not correct, because it's the next step in their treatment. And then radiation therapy alone is only reserved for people who are a very poor functional status, and this is only used for palliative settings. And so, hopefully most people who present can at least tolerate undergoing chemotherapy and radiation. And chemotherapy alone has worse survival as compared to chemoradiation together. So that is why B and C are incorrect. And then immunotherapy is reserved for palliative scenarios after chemoradiation. So again, it's the next best step in the management. Okay, question 10. A 47-year-old man is brought to the emergency department by emergency medical services after delayed extrication from a burning apartment building. I'm so sorry, my mouth is really dry. On physical examination, his mental status waxes and wanes. He's also noted to have singed nasal hair, carbonaceous sputum, and full-thickness burns over his torso. He is immediately intubated and aggressively resuscitated. However, the patient becomes increasingly difficult to ventilate, despite imaging confirming the appropriate position of the endotracheal tube. Which of the following is the best next step in management? A bronchoscopy to evaluate airway injury, incision from the burn wound through skin and subcutaneous tissue to the level of the muscle fascia to relieve all involved compartments. C, hyperbaric oxygen treatment. D, incision from the burn wound through the skin, subcutaneous tissue, and underlying muscle fascia to relieve all involved compartments. And then finally, E, excisional debridement of the burn wounds and grafting. And so here, I think really important to keep in mind what the problem is. He's not ventilating, and it wants to know the best next step in management. So as we're waiting for people to answer, clearly, B and D seem to be very popular choices. And they're very similar, so that's kind of a flag. Okay, looks like we have a little more than half of folks who've answered. So the correct answer for this question is B, incision from the burn wound through skin, subcutaneous tissue to the level of the muscle fascia. Excuse me, to relieve all involved compartments. What's being really described here is an escharotomy, and that is performed only through skin, soft tissue up to the level of the muscle, not through the muscle. So that is a difference between B and D. In the muscle fascia, if you're doing that, then that's a fasciotomy. A bronchoscopy could certainly be warranted, but that your endotracheal tube is in the right position, and you have burns across the torso, and you're having a ventilation issue, not an oxygenation issue. And so that is one clear differentiating factor here is that your airway's in appropriate position and you have a ventilation problem, not an oxygenation problem. And so you need to allow for better ventilation, which can come from relieving those eschars. And then debridement of the burns, wounds, and grafting certainly comes later on and not part of initial management. Okay, question 11. Just a couple more left. A 27-year-old, 75-kilogram man who suffered a 32% total body surface area burn is brought to the burn center for initial evaluation and treatment. The patient is given, 2 liters of lactated ringers on transport to the hospital. And upon arrival at the burn center, his resuscitation was continued. Which of the following urinary outputs is consistent with adequate fluid resuscitation in this adult? A, 25 milliliters per hour, B, 40 milliliters per hour, C, 85 milliliters per hour, D, 100 milliliters per hour, E, 120 milliliters per hour. So just keep in mind the data that it gave you, which is the weight of the patient. Okay. So you guys are thinking about things here. Let's see. Okay, looks like most people picked B, which is the correct answer. About a quarter of the folks picked C. So let's talk about why B is the right answer. So the modified Brooke formula or the rule of tens should be used to estimate fluid resuscitation for a burn patient. And urine output is used to titrate the hour-to-hour infusion rate. And the goal urine output that you're really trying to achieve is 0.5 to 1 milliliters per kg per hour. And then in children, it's 1 to 1.5 milliliters per kg per hour. So in this patient who weighs 75 kilos, the urine output of 40 mLs per hour correlates to about 0.5 mLs per kg per hour. And it can range anywhere from 30 to 50. So with regards to all the other options, being C, D, or E, these are all very high rates of fluid resuscitation. And when you give this amount of crystalloid to a patient, it really seeps into the capillaries and causes over-resuscitation without a shown benefit in long-term outcomes and improvement. And then certainly the answer A at 25 mLs per hour is inadequate resuscitation and is not meeting that goal of 0.5 to 1 mLs per kg per hour for an average sized adult. And so that's why A is not correct. It's too low. And then the other three are just too high and doesn't have the improvement in excessive resuscitation that you would want to see without a benefit in end organ perfusion or long-term outcomes. And can lead potentially to increasing, of course, pulmonary complications and prolonged intubation and pneumonias and things like that. So, okay, question 12. Which of the following is true about starvation and major stress, meaning trauma, burn, or major surgery? A, starvation is associated with a higher metabolic rate than major stress, excuse me. B, amino acids from protein breakdown are the major source of energy during major stress. C, major stress is associated with more protein breakdown than during starvation. D, hypoglycemia is a common occurrence during major stress due to depletion of glycogen stores. And then E, starvation is not associated with changes in insulin glucagon ratio. And so as you guys are answering this question, just, you will get some nutrition questions. It is important to have a good understanding of the basics of nutrition, whether it is the pathophysiology or kind of more standard day implementation of parental and enteral nutrition. And these questions can certainly be tough because we don't learn as much about nutrition as we should. Okay, looks like most people answered C. And that is the correct answer, which is major stress is associated with more protein breakdown than during starvation. And so there's a real difference between starvation and stress. During starvation, you actually have a lower metabolic rate, not higher metabolic rate, because you're trying to preserve. And during starvation, the body really relies on your glycogen storage, which is limited and usually used within the first 24 hours if you're not fed and you're not stressed. And then after this, it goes to use of fat stores. And so during major stress, you have hypermetabolism, and during starvation, you have a decreased metabolic rate. You use fat as your major source of energy during stress and starvation, maybe not in the first 24 hours, but certainly after that. During major stress, you use more protein than you do during starvation. And then during major stress, you have hyperglycemia, not hypoglycemia. And so those are the real explanations. And this is definitely tough and goes back to some of the stuff we learned in medical school, but really important to note the difference between stress and starvation, and when we use protein and when we use fat stores during those periods of time. Good question, but certainly a tough one. Okay, last question, another nutrition one. A 40-year-old woman with a recently diagnosed metastatic small bowel neuroendocrine tumor presents to the emergency department with complaints of a skin rash, diarrhea, and intermittent flushing. The family members who are accompanying her also report a recent lack of short-term memory. Which of the following is the most likely diagnosis? A, vitamin E deficiency, B, vitamin B12 deficiency, C, 5-HIAA deficiency, D, niacin or vitamin B3 deficiency, and then E, vitamin B6 deficiency. So also a tough question, somewhat of a memorization question. So kind of hard to work through this in terms of ruling things out. You can think about things as with regards to vitamins and minerals in terms of fat-soluble vitamins versus minerals. That might help you distinguish some of the ways that people present. So it looks like we have not close. More than half everybody's answered, and looks like most of everyone's answered D, which yay is the correct answer. So niacin or vitamin B3 deficiency is the right answer. And these patients present with dermatitis, dementia, and diarrhea. That's kind of the triad of pellagra. So important to know kind of that presentation for these patients, and the fact that the patient also has a neuroendocrine tumor of the small intestine, which is important in that presentation. Tryptophan is the precursor amino acid to the synthesis of both serotonin and niacin. And these neuroendocrine tumors will often shift tryptophan metabolism towards serotonin synthesis, and this results in a deficiency of niacin. And so important to remember that in the algorithm of patients with neuroendocrine tumors and how they can present. And then otherwise important, the other way you could answer this question is just knowing how these vitamin and mineral deficiencies present in patients. And picking out, most of them have stomatitis, so that's not a good one to remember, but kind of picking out the key differences between the vitamins will help you remember which deficiency or presentation goes with which vitamin deficiency.
Dr. Hennessy, another phenomenal presentation and review of those questions. Thank you so much. We'll turn over to Dr. Haskins to close us out for the ABSITE or general surgery review for this year.
Yes, so I think we have everyone back with us. Just again, another thank you to all of our panelists for being here with us tonight and sharing your expertise on these topics. We would again like to remind all of you who are still with us of the upcoming SAGES annual meeting, which will be held in Tampa, Florida on March 25th through 28th of this year. We would also again like to take a moment to thank Gore and TrueLearn for their contributions to this webinar tonight. The recording for this session, as well as all of the other SAGES webinars, including the General Surgery Review Part 1 from December, will be available for your re-review on the SAGES website, hopefully by the end of this week. Again, thank you to all of you for being with us this evening. Please take a minute to complete the post-activity survey so that we can continue to improve these education sessions. We wish you the best of luck on your upcoming ABSITE exam, and we hope you all have a good evening. Good night, everyone.
Good luck and good night, everybody. Thank you.
Bye.